one I just got now pay for the alcohol.
Okay.
You want to use 8?
One of these.
Yeah, it was a pair.
So, did anybody see an epidural put in last week? Is it jiving with what you're hearing? Is there anything that you saw? Is there anything you would want to add to pass on to your friends about epidurals? They miss sometimes. Yes, so it's good to have somebody who's very good at putting epidurals in. It should get easier, but it does take a while for it to take full effect. So like while you're in that position, you have to breathe and hold still so that you don't move when they're trying to put the epidural in. They usually do a test dose and then make sure you tolerate that okay, and then the contractions will slowly get easier, but it takes about 10, 15-ish, 20-ish minutes to get full relief from the epidural. So
Is a nurse always in front of them to like make sure that they don't move?
a nurse needs to be in the room with the patient when they're, yes,
Like,
absolutely.
the nurse was standing like in front of her, like hands on shoulder, like making sure she didn't like lurch backwards.
Right, and so some nurses actually put their hands on the shoulders, but some nurses, it just kind of depends on the patient. Sometimes anesthesia wants you to put your hands a certain way. So why get an epidural? Epidural, you can be awake, so you are cognizant when you're not drugged up or loopy or have altered perceptions. You're not remembering things incorrectly. We can give you different dosages. It can also be used, so if there's a risk that you might be a C-section, they can quickly go back to C-section and use that same epidural. And then this is postpartum tubal ligation. So if a woman wanted to get her tubes tied, they could actually do that within about an hour or two after delivery. They use the same epidural and they don't have to wait. So it's like they can get it all done and over with. Usually for that, they would just make a little incision in the umbilicus. It's about an inch or so. They go in, it's laparoscopic, they fish out the tube, they cut the piece, they fish out the other tube, cut the piece, and they stitch it back up, and then you're in recovery room and your baby's there. So it's again, you just have all that recovery together. Usually for tubal, you sign paperwork maybe 30 days prior to delivery, because they want to make sure that it's definite. In other words, it's not like you just had the baby and you decide right then and there you're done having babies. That would not be appropriate. It's a permanent decision, so it needs to have some time and reflection. The big disadvantage for epidural, and the thing that we see most commonly, is hypotension. So what would that make the baby's heart rate do? What? Not increase. You could have a decel. Whenever I say decel, people think I'm talking about batteries. No, I'm not talking about batteries. Deceleration. There's a specific type of deceleration. Late decels. And so, I think I mentioned this the other day, heel chop. It's an oldie but a goodie. Again, been around. I think I had this in nursing school, so it's really old. Variables are caused by cord compression. Earlies are caused by head compression. Accelerations, this is not a decel. The accelerations in the baby's heart rate means the baby's oxygenated, and late decels are caused by perfusion problem. So hypotension affects perfusion, so late decels. Sometimes what you'll see post-anesthesia with the epidural, if mom is sleepy and mom is resting, then sometimes your variability will change a little bit as well. But again, that period of kind of minimal variability without decels should only be, 30 minutes, 45 minutes or so. Late decels are different than minimal variability. Late decels are an indication that there's a perfusion problem. And in some cases, we give a fluid bolus, but in some cases, anesthesia will give ephedrine. And they usually will either give IV or IM, so that's ordered by anesthesia. It's not the nursing judgment to give that. As I mentioned, the full onset may not occur. The other thing with epidurals is sometimes they can be one-sided. So when you put the patient back in bed, you want to kind of wedge to a wedge underneath the hip. So you have to constantly turn and reposition your patient. If your patient always wants to lay kind of on the left side, that epidural infusion is gonna work by gravity. She's gonna be super numb on the left and have a lot of pain on the right. So you're constantly having to kind of move her and reposition her to keep her block even. You need a skilled person to do it. And the other thing is, once you have an epidural, you're gonna be on the monitors continuously. So mom's often on telemetry, she might be on a pulse ox, and then you have monitors on the baby. So if you don't want all that belts and stuff, you don't wanna be kinda hooked up to all that, this might not be a good option for you for pain. All right, so this is from the book, and I think it is ultra confusing. So the only reason I bring it up is, it tries to delineate what are absolute contraindications versus which things are relative, meaning it could or it could, it just depends. I think for me as a nurse, anytime I see anything on this list, I'm concerned that the patient may not be a candidate for epidural, okay? But again, it is generally the anesthesiologist and the obstetrician, midwife's decision about whether the patient is going to get an epidural or spinal. And honestly, the person who weighs the most in that, sometimes the patient, but it's anesthesia. Anesthesia is the one. So if we have a patient who has some type of health problem, and we know that during the pregnancy, they will actually have the patient consult with anesthesia during pregnancy to see whether or not they are a candidate for epidural or spinal. The other thing you may find is that a patient may not be, anesthesia at a small community-based hospital may say, nope, we're not gonna put an epidural in you, but then they bring you to a large tertiary care center and anesthesia will put an epidural in. And it has to do with they have the resources if there's a complication, that they can attend to that, okay? So that's why I feel like you will have taken care of a patient who had hypertension and she got an epidural. You will have had a patient who had a hemorrhage and they put a spinal in, okay? So I think this list is confusing. So I would not try to delineate what's absolute and what's relative, okay? But if you look at this list and just think about it from a logic perspective, well, obviously, we're not gonna put epidurals and spinals in people who refuse them. That's assault. But if you have infection or a volume problem, if you have bleeding disorder, again, those are potential complications. And the issue is that they don't wanna have hemorrhage around the spinal column, spinal fluid, because that could, again, cause permanent damage there. So, the short version, I'm not sure I would get too wigged out about memorizing everything on this slide, okay? But I think, again, the idea is if my patient has something significant in their medical history or they have a complication in childbirth that may impact whether or not they're able to do epidural or spinal. All right, so this is nursing care of the client with anesthesia. Want to make sure the consent's been signed. We need to look at the labs for epidurals and spinal. The big thing that we want to watch is the platelet count. That's usually what anesthesia wants to know. We'll get her on the monitor. We'll check her vital signs. The nurse usually starts the IV. A lot of times you'll see the nurses start an IV and it's like they never logged into the computer. Did they do that independently? And you have to remember, there's standing orders on admission and also standing orders for anesthesia. So once the orders for anesthesia come in to say the patient can get an epidural, there's some standing orders there that say bolus the patient with fluid. So it's not the nurse just independently making that decision. The other thing is, the nurses do it so much that they know we need to bolus this patient with fluids. Again, we usually will put the patient in a lateral position or a sitting position, and then you're watching the client to make sure they don't move during the procedure. The other thing is you don't want the patient reaching back and touching the sterile field. It should be inserted using sterile technique. The other thing is you may need to pull meds for anesthesia from the Pyxis so that they can use those. Lots of safety issues related to epidurals and spinals. A lot of our lines should be marked. So those of you who saw epidural put in, did they put stickers on the line to say epidural? Because we don't want to accidentally put something in the epidural epidural line that was meant to be in the IV. Like, you wouldn't wanna give ephedrine push through the epidural. Ephedrine push would be through the IV. So a lot of safety, interventions have been that we label those lines. They have a different color sticker. You always wanna check your line, cause the epidural catheter, it's taped in the back and it tends to hang right here, and then it's connected, there we go, connected to the epidural infusion. And again, as a nurse, I can turn the epidural off, but I cannot adjust the rate. I can't turn it up, I can't turn it down, I can't restart it. I can turn it off if I need to, if the patient's having complications, but when it comes to bolusing and re-injection, anesthesia has to come and do that. So how can I use the same epidural? What we do is we tend to change the patient's position. I like to show this picture because I just want to make a note, because I think as a student it can be confusing. When you look at this picture, you think we can put her flat on her back. We should never have pregnant people flat on their back. And the concern there is that we're going to see decels in the baby. It impairs perfusion to the baby, but it also prevents venous return for the mom. So she really needs to be tilted. But what we will do is we do tend to put the head of the bed lower when they come in bolus and they give that medication through the epidural for C-section. So they use more medication, they do lower the head of the bed down, but the idea again is to get the block higher, right underneath the breastbone, because epidurals work by gravity. So the nice thing about spinal anesthesia, it's a one-time dose. They will inject medication through that. Again, it's performed by anesthesia. And then we can quickly lay her down, and the block takes mere minutes to give you a full, complete block. So with spinal, the patient has no pain, but also doesn't have sensation there, which is kind of nice for a C-section. Think about it. If you're a patient getting a C-section and you have epidural, you may still feel them kind of pulling here, and that's a real disconcerting feeling. And you have pressure and people pushing on the baby's head and stuff, and less so with spinal because you're more numb there. The other thing about spinal that I've seen recently as a change in practice is emergencies. Even in emergency situations, they'll go ahead and do spinals now because we do so many of them, we get really good. And you have to remember, the hospitals that we're at for clinicals, we do this a lot. Our anesthesiologists have been there a lot. They're very experienced, so they're very good usually at getting epidurals in. So very small drug volume, nothing in your back, so you don't have to worry about dislodging anything or being careful that you don't hurt anything there. The big thing about it is it does cause maternal hypotension. And so because it acts so quickly, we want to give it right before surgery. So you don't want to get the spinal and then wait 30 minutes for the surgery to start. So it's usually done in the OR, we lay her back down, we get her nice and numb, and it's a flurry of activity. So we gotta prep her, we gotta put her catheter in, and then we do the procedure. So usually the cut is made within maybe 5 to 7 minutes after the anesthesia is put in. It's that quick. An emergency situation will be even quicker.
Do you know, so why is the hypertension one of the contraindications when both of them cause hypotension?
Because the concern is that you have vasoconstriction occurring there, and it may impact the distribution of the medication. The other thing is we're concerned about seizures, and we don't really want to mess with spinal fluid if there's seizures and a neurological issue there. But again, I have seen plenty of people with hypertension get epidurals and spinals. So that's why I think it's a call made by anesthesia, it's not a call made by the nurse. And I think the way the book makes it sound like it's a call by the nurse, and it's really not. I think some of it depends on how much hypertension and what facility you're at and how skilled your anesthesia is, so. With spinal anesthesia, when they put the needle in, you will see a couple of drops there of spinal fluid, okay? We should not see that with epidural. They're not gonna get that. So you'll see them with a little glass syringe, and they're kind of testing for loss of resistance with epidural, but with spinal, there is a little bit. So if you're like helping with that and you're like, there's stuff dripping out of that needle, is that supposed to happen? With a spinal, it does. But they inject that medication, they pull that needle out, put pressure, and so it kind of seals back up again. There's nothing that stays there that keeps that hole patent, so you don't keep leaking spinal fluid out of the hole. And again, the care is essentially the same. We would use spinals for C-sections. We would use epidurals for vag deliveries and C-sections. We don't use spinals for vag deliveries. Okay. So some other types of anesthesia that are not as common, pudendal block. It's really funny because I used to say, oh, nobody ever does pudendal blocks anymore, and then sure enough, somebody said, well, I was at Baptist and I saw pudendal, you know, so I'm like, okay. I think it depends on the provider, if they're trained in how to do it. It is the book, I wanna say, calls it a regional anesthesia, but the region is really, really small. Usually pudendal block is done to block right around the genitals. And so it's really good for if you need to do an episiotomy or a laceration repair. In my experience, the provider did a pudendal block often right as the patient was pushing, so that because they were kind of in so much pain and out of control, and it provided just enough kind of anesthesia that the patient could control a little bit better. So it's again a very short type of block. It doesn't last very long, doesn't impact the baby at all. And the big risk with it is we don't want the provider, the nurse does not administer it, the provider does this, and inject that medication into a vessel, because then that medication goes systemically. So again, if you've been trained in it, it's a fine block. And then local anesthetic. Local anesthetic is usually some xylocaine, and it can be done prior to delivery. It can also be done after delivery for repair. And usually, again, it's for superficial repair. The patient will shouldn't have pain, but may still feel kind of what's going on. But this is often used for patients who had no anesthesia during labor, but they need some kind of perineal repair after delivery. So a patient who went natural might get local anesthesia for the repair if there's a tear. Now, again, what I'm seeing as a change in practice, a lot of little minor lacerations, they're just letting them go because they found that the stitch of going in with the needle and the suture actually caused more trauma than if you just let it heal by itself back together. A lot of women were getting scar tissue and having painful intercourse and painful urination when they had things repaired a lot. So a lot of times those little tiny, and some people call them like skin tears or little they'll say, oh, it was a first degree, but it was not repaired. Those are doing better. It's usually like, in this situation, it'd be a second degree or a third degree, or the heavens to Betsy's fourth degree laceration. Some OB doctors here in town call fourth degree laceration a vaginal C-section, because you're torn all the way from the vagina to the rectum. And you have such complications with it long-term often, so it's a big to-do. All right, so on to general anesthesia. General anesthesia is generally reserved for patients who, for whatever reason, cannot get an epidural or spinal, or if, again, in an emergency situation. When we do general anesthesia, they're gonna get not only IV medications, but inhaled, and then we also give the paralyzing agents, neuromuscular blocking agents. So I don't know if you all talked about in PHARM with balanced anesthesia or nursing 230. Sometimes if the right combination of those medications are not administered, the patient cannot move but can still feel things. And it's because they have the block agent, but they don't have the analgesic there. So when you hear kind of these horrible stories about, I felt everything they did, it was probably an anesthesia issue, and that the medication did not get administered in the combination that it needed to be administered. This makes your baby depressed, like respiratory depression, cardiac depression. So if you have anybody get general anesthesia, you need to have your NICU team, your nursery team there. The baby may need more active and vigorous resuscitation. The other big thing is general anesthesia relaxes all of the muscles. The uterus is a muscle. So the big concern with general anesthesia is postpartum hemorrhage, because the uterus won't contract after, because you deliver the baby when it contracted, and don't have any means to tell the body relax all these other muscles except the uterus. It doesn't work that way. So we still give Pitocin and things, but I watch her very carefully for postpartum hemorrhage and boggy uterus, so we need to check her really carefully for that. And so a patient who has uterine atony, we give her Pitocin and it doesn't work. What would be some other options for us? Cytotec, Methergen, yep, Hemabate. Those are the big three. Yep, those are the big three. So in a C-section, what you may actually see, the uterus is out on her abdomen, and if she's hemorrhaging, if the uterus is boggy, they will inject the Methergen or the Hemabate directly into the uterus on the table. Because again, she needs to get that uterus clamped down, she's bleeding so much. Some of you guys are doing position statements. This is A1's position statement concerning epidurals. The reason we bring this up, sometimes there are nurses who don't understand the scope of practice of nursing, and they do things outside of the scope of practice. I think some people are kind of have this issue with nurse-physician relationships. It's like, well, the doctor told me to do it, so I did it. And so what this is saying is, here's the things that your professional organization says that you are able to do as a registered nurse. So as a registered nurse, you can monitor the patient, but you should not insert, put an injection in, rebolus. You can't increase or decrease the rate. You can monitor the baby and mom. So if the bag runs out, it's on a pump, and if it runs out, you can replace it even Stevens and keep everything the same. But you can't change the amount that the patient's getting. And then the other thing is, for most of our facilities, the nurse might be the one who takes the epidural catheter out. So when you take the catheter out, you know, there's all that tape. So you take all the tape out, but when you pull the catheter out, you wanna inspect it, and you wanna make sure the tip is intact. We need to look at the insertion site. When you are taking care of patient on mother baby, if your patient had an epidural or spinal, you might wanna look at her back and see if there's any bruising there or anything abnormal at the insertion site. Sometimes patients are like, gosh, my back really hurts, and it's because there may be, again, some bruising there from the injection that she had with epidural. All right, on to birth-related procedures.